Welcome to this explainer. Today we're diving into the absolute masterclass on anti-epileptic drug screening models. If you're looking to score a perfect 25 marks on your pharmacology exam, you're in the exact right place. We're going to break this down so thoroughly that even if you're starting from scratch, you'll walk away totally prepared. So let's just jump right in.
All right, here's our game plan. We'll start with general considerations, then introduce our secret weapon, the smart pace framework. After that, we'll hit the MES model, chemical-induced models, kindling and genetic models, and finally wrap up with a final exam evaluation. Let's go.
Section 1. General Considerations. Setting up your in vivo models.
Okay, so before we get into the complex stuff, you've got to nail the absolute basics for these in vivo models. Think of this as setting the stage. While you could use guinea pigs, gerbils, cats, dogs, or even monkeys, you really want to emphasize that rats and mice are the gold standard here. You'll want to note that they're housed separately in groups of 6 per page with free unlimited access to food and water. For your exam, always mention the 3 crucial groups: your test drug, a standard drug for comparison, and normal saline acting as your control. How do we know if it worked? Well, efficacy is literally just checking if the drug suppressed the seizure symptoms or delayed the actual convulsion. Simple, right?
Section 2. The smart pace framework, your 25-mark secret weapon.
Now pay close attention, because this is literally the blueprint for that 25-mark answer. It's an incredibly handy mnemonic called SMART PACE. Write this down. S is for the screening model type, like in vitro, in vivo, ex vivo, or computational. M is the model used, so the specific animal or cell line. A is the aim or principle. Why are we even using this, and what disease does it mimic? R stands for requirements and reagents like your drugs and apparatus. T is the technique, basically your step-by-step procedure. Moving to pace, P is parameters observed, what exactly are you measuring? A and C are the advantages and constraints of the model. And finally, E is evaluation, how you actually interpret the efficacy. If you use this exact structure on your exam, you are golden.
Section 3. Maximal electroshock seizure, or MES, model.
Now, applying our SMART PACE framework, let's look at the requirements phase for MES. The star of the show here is the electroconvulsiometer. As you can see, this is a highly specific apparatus. It uses these little corneal or ear electrodes to deliver a precise electrical shock directly to the animal, which standardizes the seizures perfectly across the board.
Okay, let's talk numbers, and you absolutely need to memorize these for those marks. The aim of the EMES model is to induce the most intense physiological seizure possible. Why? Because it's the perfect stand-in for human grand mal epilepsy. For your model, you're using male Swiss mice weighing 20 to 32 grams, or Worcester rats at 100 to 150 grams. Now here's the crucial technique part. For mice, you deliver exactly 50 milliamps. For rats, it's 150 milliamps. Both get a 0.2-second duration at 50 to 60 hertz. When do you zap them? Either 30 minutes after an IP injection or 60 minutes after giving the drug orally. Do not mix these numbers up.
So what happens after the shock? Let's dive into the parameters observed. You'll see 5 distinct chronological steps. Step 1 is tonic limb flexion, lasting a super quick 1.5 seconds. Step 2 is the absolute most important one, tonic limb extension. This is where the hind limbs extend past a 90-degree angle with the body for about 10 seconds. Step 3 brings clonic convulsions, which vary in time. Step 4 is stupor, and Step 5 is either recovery or death. Now here's your evaluation takeaway. If your drug suppresses Step 2, that hind limb extensor convulsion, that is your definitive proof of protection. That's the magic criteria. To really flex your knowledge and make your answer bulletproof, quickly rattle off these electroshock variations. Extensor seizure latency is simply the time it takes to go from the flexor to the extensor position, normally 1.2 to 2.0 seconds. Then you've got psychomotor electroshock, which uses a lower 6 Hz frequency for 3 seconds at 32 milliamps. This one's fantastic for partial seizures, but fun fact, phenytoin actually doesn't work here. Next is the minimal electroshock threshold, or MET. This measures a drug's ability to bump up the shock threshold by 20%. And finally, the hyponatremic electroshock threshold, where you actually lower the threshold first by injecting 5.5% glucose.
Section 4. Chemical-induced seizure models.
So let's pivot to the chemical side of things. Applying our trusty SMART PACE framework, ask yourself, what is the precise aim or principle of the pentylenetrazole or PTZ model? What exactly is it doing in the brain?
Well, PTZ is a targeted attacker. It binds specifically to the picrotoxin binding site to trigger seizures. For your requirements and technique, you administer it intraperitoneally.
The dosage is 85 milligrams per kilogram for mice and 70 for rats. Why do we love this model? Because it's the absolute standard for evaluating centrally acting muscle relaxants and drugs aimed at tonic-clonic seizures. All right, for the parameters observed in the PTZ model, you have to record these highly specific visual phases. Step 1 is myoclonus. Think of it as a whole-body twitch, paired with this thing called the Straub tail phenomenon. Step 2 escalates to clonus, where you see clonic spasms, stupor, and really unusual body positioning. Step 3 is severe, clonic-tonic hindblum extension, and sadly, Step 4 is death for some animals. To prove your drug works, your evaluation step, you need to see the abolition of both tonic and clonic seizures in 50% of the tested animals.
Now, PTZ isn't the only chemical player in the game. Look at this breakdown. We have agents attacking totally different physiological pathways. Take strychnine, for example. It's a glycine antagonist that totally wipes out flexor latency, causing an instantaneous extensor seizure. Then you've got picrotoxin, isoniazid, and bacucolin. They all aggressively target the GABA system, either by blocking it or completely stopping its synthesis. And then there's 4-aminopyridine. It goes a totally different route as a potassium channel antagonist, which basically kicks off massive excitatory transmission, resulting in generalized tonic-clonic seizures, opisthonis, and death. It's like a biochemical toolkit for inducing seizures.
Section 5. Kindling in genetic models. This is where you capture those extra marks.
What makes these advanced models so brilliant is how accurately they mimic the slow, progressive nature of human epilepsy. For focal seizures, you literally apply metals like alumina cream or cobalt directly to the brain, or inject kynic acid right into the hippocampus. Then there's kindling. This is fascinating. You use repetitive tiny stimuli that don't initially cause a seizure. It could be electrical, through an amygdala electrode or corneal shocks, or chemical, like giving rats 30 milligrams per kilogram of PTZ 3 times a week for 9 weeks. Eventually, you literally train the brain to seize.
And we definitely can't forget the genetic models. These are incredibly specific testing grounds. For absent seizures, we use polygenic Geyers and WAG/Rige rats. Or look at the Totterer mice. They have a specific homozygous mutation that gives them frequent partial seizures. Then you have DBA/2J mice, which are uniquely susceptible to sound-induced seizures. There are even photosensitive baboons that get tonic-clonic seizures just from intermittent flashing lights. The sheer variety here really highlights how we can model almost any specific human epileptic condition.
Okay, to guarantee your answer is completely exhaustive, you've got to throw in the extreme clinical conditions. For status epilepticus, mention continuous perforant path stimulation for 24 straight hours. Or you can use massive chemical doses like 380 to 400 milligrams per kilogram of pilocarpine. Finally, for infantile spasms, you must cite the Volesic model. This is where pregnant Sprague dolly rats are given betamethasone and then their pups are injected with NMDA on postnatal day 15. Mentioning this shows real depth of knowledge.
Let's tie it all together. The ultimate proof of your understanding is mapping these screening models right back to the clinical seizure types they actually represent. So, maximal electroshock and PTZ, those model your tonic-clonic seizures. Amygdala kindling are your go-tos for partial seizures, and that WAG/Ridge rat we just talked about, perfect for modeling absent seizures. If you can clearly connect the lab model to the patient outcome, the examiner will have absolutely no choice but to give you full marks.
Section 6. Final exam evaluation. Let's wrap up with a little pop quiz to lock this in. If an examiner asks you to evaluate a brand new drug for grand mal epilepsy using the MES model, what is the single critical physiological parameter you must observe to prove it works? Think back to those 5 steps we covered. Got it? It's the complete suppression of Step 2, that tonic hide limb extension. Keep this smart pace framework front and center in your mind, and you are going to absolutely crush this exam. Thanks so much for joining me on this explainer, and I'll see you next time.